Today we are going to talk about assessment of the hip, and we are going to start with differentiating lumbar spine versus hip. So the first technique will be from the Maitland text. So you will have your patient stand and cross your arms over your chest, and you will have them perform the multi-segmental rotation towards the affected side. We'll choose his right, so please rotate to the right. Then you're going to come in and block their hips, and then ask them to place their hands on your shoulders. And then can you please take your right shoulder, right hand, and then place it on my right shoulder and kind of rotate this way, but keep your hips in place. So this will keep the hips rotated, but remove the rotation of the lumbar spine. So if the symptoms remain, you can conclude that the symptoms are likely coming from the hip. And you can do this with any other type of lumbar range of motion. So if you have them go into extension and they say, ow, that hurts, you can grab a step and have them place their right foot, the affected side, on the step. Now their hip is staying in flexion, but if you extend, please, and it still hurts, that could be the lumbar spine, or if the pain is now gone, it might be because the hip is going into more of that extended position as they go backwards. You can do the same type of thing with any motion. So similarly with, move your foot please. If you have the patient perform right side bending, that is relative abduction of the hip. So if that's painful, you can play with having the patient step the right foot farther out into more abduction and now side bend to the right, versus can you go feet together and now perform side bending. You could even have them cross the right foot over the left. That way they're in adduction, and then perform your side bending, and just playing with the position of the hip to see if moving the hip changes what they're feeling with the lumbar spine motion. Next, we are going to move into the passive overpressure combined motion and active portion of the hip assessment. This will be a little bit out of order of how the assignment has it listed, but I'm going to do it in the order that I would in an exam. And my personal preference is to do passive range of motion assessment first. That way I can get my hands on the patient, and the patient kind of knows what motions I'm asking them to do for later in the active range of motion assessment. So first one that we'll test here in supine will be flexion. You can add your overpressure here into end range flexion, or you can add more of an axial load through the femur. Then you can move right into internal and external rotation. So I like to cradle the leg. That way I can kind of control how much rotation is coming from the hip versus the knee. I feel like I can get a little bit more specific with the hip. If I'm holding the leg this way, then you can overpress into that end range or directly through the femur, and then same for the opposite, rotating out, overpressure. Then we can check AB and adduction while in supine. So you'll want to have the patient move their opposite leg a little bit out of the way for adduction. You're going to want to stabilize the ASIS, and then you can slide the leg into adduction and out into abduction, getting that same end range overpressure. And then while you're here, you can go ahead and check internal and external rotation with the hip in the more neutral position, and that log roll with a little overpress at the end, and then out into external. Things that you're going to be looking for here on the passive range of motion and overpressure assessment, besides just pain and reproduction of symptoms, will be with hip flexion. If you have any limitation in posterior inferior capsule or the posterior hip musculature, that range of motion will be limited, as well as limitations with hip flexion and internal rotation with hip OA. And then for the other motions, you're just thinking whatever muscles are doing the opposing action will likely be limiting that direction. So if they're limited in internal rotation, you want to check the length of the external rotators. And then with like adduction, you have considerations for the lateral capsule as well. while we're here, we'll go ahead and do our combined motion assessment next. I kind of like to roll through some of my special tests right after the passive range of motion because I've already got my hands on them. So we'll do Faber and Fadir, and for both of those, if they're positive, you're thinking more intra-articular hip pathology. So Faber, flexion, abduction, and external rotation. It is my personal preference to try to place the patient's ankle above the knee, stabilize at the ASIS, and then ask them to relax the knee down. That way you can add a little bit more overpressure if needed because their leg is already stabilized. Fadir will be flexion, adduction, and internal rotation, so we'll bring them up, over, and rotate. For this one, you can add that little bit of overpressure as well, using your third arm to grab that ankle, rotating them, and then adding that axial load into your Fadir. Then after we've done our passive and combined motions, I'll ask the patient to run through the same motions that we just did, but actively. So can you please bring that knee as far as you can up towards your chest? For this, you may want to also palpate the ASIS to see when you start getting pelvic motion as well, because that will tell you where your end range hip flexion is also at. Then stay here, and can you rotate your leg to bring that ankle in and then out, just like we just did, as far as you can. Good, and then let that leg relax down, and then I want you to move that leg out of the way, and can you slide that leg in and then out, and then same thing with both of those. You will want to palpate ASIS, and then you're going to be taking your goni measurements as well. So just making sure that you're monitoring when they're getting any pelvic or lumbar movement so that you can accurately assess and record where the hip motion actually ends. Okay, then there are 3 motions, passive accessory motions that we can assess while in supine. So the first one I'm going to do is going to be that inferior glide. So you'll have the patient scoot as close as they can to the edge of the table. You're going to, ideally you would be at a high-low so that you would not have to get as low to the ground as I'm about to get. I would not be able to do this for a very long time on a real patient, but you're going to put their leg over your shoulder with their knee resting here. Ask them to relax their leg. I like to interlace my fingers to make a little cup shape. Hook that into the front of the hip, and then perform sort of a scooping motion as you lean your body back to feel that inferior glide of the femur. So coming in here, and then making that scoop and pulling down. Next, we will perform a lateral glide. I do sometimes like to kind of combine inferior and lateral. That seems to be really comfortable for patients. Ideally, we would have the belt that has the pad on it, but I don't have one, so we're going to make do with this. And typically with patients, I will ask them to place it on themselves. I just ask them to please place this strap deep into the crease of your hip, as close to you as you can possibly get it, and make sure it's nice and comfortable. Then I'll strap myself in, stabilize on the knee here, and then just lean back into that belt to get that lateral glide. And then to combine with inferior, I like to lift up the leg, bring them into some rotation, and then you're going to be pulling back at this angle, kind of this diagonal angle, for that inferior lateral glide. And I'm going to treat his other leg for the posterior glide, so you can scoot back to the center. Then you'll have them straighten the unaffected side, cross the affected side over with the knee propped up, and then your force is again going to be that kind of more like posterior lateral motion. And they should feel that stretch kind of in their back pocket as the description I like to use. If that is not comfortable or an attainable position for your patient, you can go back to that leg over the shoulder position, and you can provide your posterior glide this way at varying degrees of hip flexion, just pushing straight down. All right, then we will move into side lying for distraction, and then you can also get an A to P and a P to A in this position. So for distraction, you're going to find the greater trochanter here, and you can kind of place your hands on top of each other, find that greater trochanter, and then just push down for a more specific hip distraction in a side lying position. You may want to consider placing a pillow between the patient's knees for more comfort. Then for the PA and AP, I have to admit this would likely not be my preferred technique. I think it's a little rough on the thumbs, but you can get the P to A and then the A to P by doing kind of like a bowstring type technique on the hip. So you're going to find that greater trochanter again, kind of thumb and dummy thumb right over it, and then you're going to want to bow the hip to get the P to A, and then you do the reverse for the A to P. So you're going to go the opposite direction, pulling in, or I'd recommend swapping sides. That way you can get more of a push. I think a push is always easier than a pull. Okay, next we are going to check passive and active hip extension. For me, the easiest way to do this is to flex the patient's knee. I like to put my inside hand underneath the patient's knee. That way I have good control, and then I can block the pelvis with my opposite hand. And then I just kind of lean or lift to get that hip extension. Then now my patient knows this motion, so I'm going to ask him to, can you please repeat that? Try not to use your back, try to just use the muscles of your hip, and then I'm also going to come in and stabilize, and can you lift that leg up off the table? And then relax. And then we have one more passive accessory motion to assess in this position, which is the P to A. We already saw that inside line, but this is definitely my preferred position. So you can do it with the leg just extended out this way, finding the greater trochanter, and then giving that P to A force. I do also like to, just for the patient's comfort and just feeling more in control of the movement, I typically like to hold on to the patient's ankle, find that greater trochanter, and mobilize here. That way I can move directly into that more frog leg position if I want to make the mobilization a little bit more intense or work on that rotation range of motion, or I can provide a mobilization with movement really easily without having to stop doing the mobilization, change the patient position, anything like that. So you can start here, and then you can glide and move into rotation, or you can go ahead and place the patient into that frog leg position at their end range, which is here for him, and then mobilize, stretching that anterior capsule.